Hello and welcome to eviCore Healthcare's educational webinar series. My name is Bill Cornelius with eviCore Healthcare. eviCore empowers the improvement of care by connecting patients, providers, and health plans with intelligent evidence-based solutions to enable better outcomes. If you would like to learn more about eviCore, please reach out to sales@evicore.com for more information. Throughout 2021, eviCore will host free educational webinars that include guest speakers, as well as eviCore subject matter experts, to discuss today's most pressing healthcare topics. Stay tuned for our future webinars with new topics presented each month. And now it is my privilege to introduce you to our panelists. First is our guest speaker, Billy Willwee, who is the president of Willwee Associates. He will be joined by Dr. Yvette LeFebvre, Chief of PAC DME and Sleep Services at Evernorth Home Solutions. Together, they will take a closer look at emerging trends in Medicaid Managed Care and the challenges and opportunities they present from both clinical and business perspectives. Before we begin, just a quick reminder to please submit your questions using the question feature in WebEx. Jenny Ritchie, Vice President of Evernorth Home Solutions, will help us facilitate incoming questions. As a reminder, this presentation will be recorded and will be available following the webinar at evicore.com/insights. Team, I'll turn it over to you now.
Thanks, Bill. Hi, Billy. Thanks for being with me today.
Good to be with you.
So before we start talking about emerging trends in managed Medicaid, I think in order to understand where we're going, it's a little bit easier if we understand the past. So do you think that maybe we could start with a little bit of a managed Medicaid history brief?
Sure, glad to. I've been in and around the Medicaid program about 30 years now. Spent a number of years in Texas Medicaid, serving as the Texas Medicaid director. So I feel like I've kind of grown up with managed care, because if we can go back to the mid-90s, when Medicaid, as some may recall then, was largely fee-for-service. The problem with fee-for-service is the budget problem it poses to states. Medicaid consumes about 25% of the state budget. And if you can imagine, you have this fee-for-service program where you can't predict cost. There's not a whole lot of utilization management going on. In fact, I used to joke that in those days, when someone became eligible for Medicaid, the Medicaid eligibility card was much like a hunting license, where you would go out and you would hunt for care and you would find it wherever you would find it. The entering argument for managed care in those days became, we've got to have more budget certainty. We just got to have more budget certainty. And so you had many states that started looking at it and said, you know, it does become more manageable if we move into managed care and we can use the PMPM to predict what our cost is going to be and come in closer relative to being budget certain. And that was kind of the history. And back then we were talking largely about pregnant women and children coming into Medicaid, not real complex cases, but would benefit from management, and also that budget certainty that was so important in the early days.
Thank you. That foundation, I think, is really helpful. And I'm hoping that we've moved a little bit away from just issuing hunting licenses, right, to our patients for their Medicaid. So now that we've kind of got that foundation, let's move forward a little bit. How would you say managed Medicaid has changed or evolved since, let's say, the early 2000s?
Well, you know, it's evolved along with the Medicaid program, to be honest. You know, going back to the early 2000s and mid-90s, Medicaid was very small compared to what it is today. You know, today we have potentially 71 million lives at any one time touched by Medicaid. It's a $700 billion program. Medicaid is projected to be $1 trillion program by 2026. And the demographics are going to be so much more complex. So we've kind of moved away from this model of budget certainty for a relatively healthy group of population of pregnant women and children. And we're moving more and more complex populations into managed care. And what I mean by that are the populations of elderly and disabled who are duals, who are both qualified for Medicare and Medicaid, children with complexities, children with disabilities, and foster care kids. So And this is a population, that would most benefit from management, both from improved outcomes and cost perspective too. Because when you look at the Medicaid population, it's generally that 75-25 or 80-20 rule. 25% of the population drives 75% of your costs. And so those are the ones that are going to be much more beneficial. So we've kind of gone from this model of budget certainty now to focusing on complex populations with very, very complex healthcare needs and demanding more from the managed care plans, and not just being budget certain, but driving improved outcomes, cost containment, improvement along a multiple of outcomes. So there's much more demands being made by the state now than there used to be.
That's interesting. And that's a common theme. When I talk to our managed Medicaid partners, right? The provider, both the providers and the payers, I hear about those increasing demands, right? That's just like you said, we've got increasingly complex patients. We're trying to manage them. The states are expecting a lot of us. So maybe you could give our managed care partners some ideas about what you consider to be keys to success for their programs.
Well, increasingly, states are pointing to service coordination, care coordination, case management is important. Sure. And not all populations will benefit from that. So it's looking to plans to see what kind of stratification models they have in place that will identify those members who actually will benefit from care management, care coordination. So having very, very firm programs there that kind of put the patient in the middle, and then have all the community, the healthcare evolve around the patient so that they're getting the services that they need at the level that they need them. Cost containment and quality are certainly on the top of mind. Many states. Texas recently implemented, as a matter of fact, a algorithm that favors a plan that is more cost efficient, has higher quality in the way that defaults are allocated. Defaults are really important. Defaults are members that do not select a health plan, so the state defaults them into a plan. They're typically low utilizers as well. So they could be of great value to the plan. So the plans that perform better on cost, and the measurement looks at predicted MLR versus actual MLR, and then several quality measures and patient satisfaction measures, benefits from a greater proportion of members who are defaulted into that plan. Thirdly, innovation. States really rely now, since the state is not managing the service, they're depending on the managed care plans to bring innovation to the model. And things that you're hearing now, particularly COVID has so much emphasized this, social determinants of health. And there was some passive movement several years ago in Medicaid around SDOH, and now it's becoming more and more important, along with health equity. In fact, CMS is telling states to develop models that they can track health equity and progress in addressing health equity. So those are certainly key and getting a lot of attention in state managed care procurements. Thirdly, alternative payment models. Generally, this started in Arizona Medicaid several years ago, where a percentage of the premium was required to be placed in alternative payment models, value-based payments. That's increasingly become so. 25%, I think, is where they will start out. And they ask that the plan demonstrate a model that comports with the Healthcare Payment and Learning Action Network. And that means moving providers from a process-based payment model to a full risk model. And depending on the state, that can be very difficult to do and requires a lot of working with providers. There's also increased focus on home and community-based services. Home health care, private duty nursing, personal attendant services, those things that are very much needed by the community they're serving with disabilities. In fact, the American Rescue Plan, the ARPA, American Rescue Plan Act, increases funding to states by 10% on the federal matching rate for bolstering its home and community-based services. It's an alternative to nursing homes. The focus is on keeping more and more people in the community versus being institutionalized. Greater emphasis now on integration of behavioral health programs. Several years ago, it was not unusual for a state to have a behavioral health managed care plan and a physical health managed care plan, and now those are both being integrated. You'll hear more and more about something called state-directed payments. Prior to the April 2016 managed care rule from CMS, states were allowed to pass through payments to providers using managed care. And this was not a payment associated necessarily with utilization. This was a pass-through payment largely funded by counties, public health districts who provided the money to the state. It would be matched and passed through the plan for payment to the provider. That was eliminated. Now states have these state-directed payments that they're made through managed care for specific hospitals, for providers, for doing certain things, for increasing access to care, for improving visits, any number of things. And so more and more health plans are getting involved with that process. The 21st Century Cures Act required the integration of the electronic visit verification. Right now, some states are migrating towards that. There's different levels that require different home delivered services to be integrated with EVV over time. But to be adaptive in how you use the EVV and how you use the data, because you can use the data to really check your network viability. For instance, if you're authorizing a number of hours through EVV and you look at the data and those hours aren't being filled, that could be an insight into your long LTSS network. Member engagement are really becoming a top priority, particularly as COVID has shown us, is that some of these members kind of fell off the map, if you would, during COVID. So states have been emphasizing being more engaged with your members, either in a digital way or reaching out with your care management, care coordination. So increasingly, in my mind, quality and cost are becoming the keys to successful business development.
That makes a lot of sense. And I have to tell you, over the years, I've always heard that there's a challenge engaging Medicaid members, especially right from our client partners. Really, really scary to think about the fact that got worse during COVID, right? During this global pandemic, where so many of our vulnerable, so many of our Medicaid patients are vulnerable to begin with, right? And now we are having a harder time engaging them. That's a lot to process. That's hard. Yeah. So switching gears a little bit, but still staying focused on our managed Medicaid partners here. Do you have any tips on approaching procurement bids?
Yes, I do. I worked on a number of bids, and both as a state regulator and also as a consultant. And what you're really wanting to do is you don't want to write an aspirational bid. You want performance data, points you can point to, data points that show how successful you've been in provider satisfaction, in member satisfaction, in quality measures, in reducing costs. All those things are going to be extremely important to states as they start looking at who they want to partner with on their managed care bids. So a history of good performance, solid performance, great relationships with providers, great relationships with members, very much engaged, and thinking forward, bring some innovation to the table. We talked earlier about the SDOH and health equity and those things. Bring those ideas front forward to talk about them and the results that you've done. So I would just say it's results oriented, not aspirational.
So that's helpful. Thank you. And it seems like there's probably a fine line between being aspirational and showing that you're being innovative, right?
And you can be aspirational and talk about how you use data to refine your processes.
Okay.
But it's really great to be able to point to how you've actually maintained your cost, but also have kept pace with your quality.
That makes sense. All right, so now let's switch gears a little bit more. Thinking about the fact that anyone, even peripherally associated with healthcare, has probably heard about the challenges associated with prior authorization, right? And I think you and I could probably spend a full day or more talking about what some of those challenges are and how we're working really hard to try to address those challenges. But for now, I was wondering if you can tell us why you think that prior authorization really is still a key component of a complete utilization management program.
Well, I think there's a couple of examples I could point to. One specific to Texas, then I'll talk about another state that had a really different experience. In Texas, there was a point when we didn't require authorization for OB ultrasound. And you would think that, well, okay, it's not really a high cost service. Why would we want to manage that? You know, it's something that's generally part of the whole prenatal care experience. But when we started looking at the data, we had a major surprise. It was, we found that on average now, OB ultrasounds were 7 per pregnancy. And we were paying for each one of those separately. And on the high end, we actually found a couple of cases where there are more than 30 OB ultrasounds. And if you look at the ACOG recommendation, it's 2 even in a complex pregnancy. So when we put a level in place and said, no, you can have 2 ultrasounds per pregnancy with others additional being allowed by prior authorization, well, the number dropped because again, we're watching it, and truly there's very seldom a reason why you would want to do more than 2 OB ultrasounds. And that was in conversations with the professionals in the obstetrical area. When we were looking at our policy, in fact, we started calling other states about how they managed OB ultrasound. And a friend, and I won't name them state, but they had an experience where they had OB ultrasound on prior authorization from day one. And they looked at the data and said, you know, gosh, we're approving 95% of these. Let's just take this off prior authorization. And we don't seem to have a problem with it. And a year later, they were in the same position that Texas had been in before we instituted our policy, because they took it off prior authorization. And, you know, it's just so easy to do if you don't have to prior authorize it and you have an ultrasound machine there and the state is willing to pay for it. So, you know, it's a way to manage costs, but not only that, but in some cases, protect the health of the patient. We had a similar experience when we didn't require authorizations for complex imaging or more sophisticated imaging processes, MRI, CT, and we started looking at the data, and there were cases where we were having children who had gotten full body x-rays. And, you know, that's dangerous. That's dangerous to the child. So I think utilization management through prior authorization still has its place, no doubt, in a fully managed care program.
I think those are great points. And I think all of those were great examples, but that final example there, right, where prior authorization is actually improving quality of care, right, protecting the patient from unnecessary radiation in that example, that's huge. And that's something that not everybody thinks about. Not everybody realizes that prior authorization really can have a positive impact on quality of care. So
yeah, and that's something we always try and emphasize is prior authorization really isn't there to necessarily deny the service. It's to make sure the patient is getting the correct service. So many times, I know probably in your experiences, you might have said, well, you don't need an MRI, what you really need is a CT, or you don't need that with contrast, you can do it without. So there's some things that are there. It's not really there to necessarily just deny the service, but make sure they get the appropriate service.
Absolutely. And you know, to that point, right, it's not common, but there are times where we'll actually recommend a more expensive service, right?
Yeah,
one of my medical directors called me recently and said that she was in her post-acute care program, medical director, reviewing a case. You would think straightforward request. The provider was asking to send their Medicaid member to a skilled nursing facility for some rehab. And when she looked at the case, this was a young guy with a spinal cord injury who was previously completely active. And when she looked at the case, she said, really, this guy needs to go to an inpatient rehab. He's going to do better in the long run. And at the end of the day, will decrease total medical cost and improve his quality of life if we actually send him to a higher level of care. Yeah. And when she reached out to that attending physician, I think he fell on the floor. He said, wait, you're telling me that I should send him to a more expensive place? And she said, absolutely, it's the right thing to do. So I think—
well, you can't be competitive on cost and quality if you're issuing inappropriate denials of service, because you know as well as I do, that's going to show up. It's going to show up in more frequent ED visits. It's going to show up in more frequent hospitalizations and readmissions. It's going to show up, and it's penny wise and pound foolish. So you want to have a program that is evidence-based, that provides the right care at the right time.
Exactly. Do the right thing. So staying on that subject, but moving a little bit to the side here, right? So we all understand that prior authorization is absolutely a key component to a complete utilization management program, but it's a component, right? So what are some of the other ways that our managed care partners can manage healthcare utilization beyond that prior authorization?
Well, I think there are a number of things. One is, to use evidence-based guidelines for one, to really inform your process. Make it. I don't want to say easy for providers to use. Maybe that's the wrong word, but certainly administratively simple. So to the degree that you can automate some of these requests, do it, where you can get an approval in seconds. That's it's not a prolonged process. It's not a huge administrative burden, and that's what I think providers generally complain about. Make sure that you're using that system to help you improve quality. Like I said, getting to the right care at the right time with the right service is going to help you achieve your goals. Using algorithms to identify potentially unsafe, wasteful, or costly patterns is helpful too. You can analyze your provider practice patterns to look at what your providers are doing, get some feedback, and understand how providers are adapting to your program. Explaining your process to providers so that they have readily available your evidence-based guidelines, so that they know that, hey, this is not a black box. This is something that is totally transparent, informed by the professional literature, and one that has been completely available to you. So I think those things combined that start forming the basis for a good prior authorization program.
Those are all of my questions. I think we can invite Jenny Ritchie on at this point to see if we have any questions from our virtual audience.
Okay.
Sounds great. Thank you, Billy and Dr. LeFebvre, both, for an excellent overview for the trends in Medicaid managed care and the challenges and opportunities they present from both a clinical and business perspective. Your presentation was extremely helpful in improving our understanding in the very complex field. So now we will begin our question and answer session. As a reminder, please submit your questions using the Q&A panel of the WebEx. So I'll give it just a minute so we can tally our questions here. And it looks like we do have a few questions, Dr. LeFebvre and Billy. The first one is, what is the basis for continuing prior authorization when 95% of prior authorizations are approved?
Well, I think I touched on that a bit with the example from another state. We were looking at OB ultrasound, where they actually had OB ultrasound in place for authorization for the service. And when they took it off, it skyrocketed. Another example I can point to is an experience we had in Texas with orthodontia care. We had a group who were doing the prior authorization work for us, but they weren't really looking that closely at the need for the service. It wasn't really tied to an evidence-based model. It was more subjective. And so virtually any request for orthodontia that would come in was getting approved. We had like a 95% approval rate. And that caused some alarm to think, well, gosh, is this something that we need to prior authorize? And we started taking a deeper dive on it and found that the clinical criteria were not actually the way they should be. So there are a couple of reasons. One is the sentinel effect it creates, and the other is making sure that you have the right criteria. If you do have a 95% approval rate, it could be that your evidence-based criteria is incorrect. In Medicaid programs only can pay for orthodontia services when they're medically indicated, medically necessary. So only for severe occlusion. So there was no rationale to support the underlying approval of those other than the evidence-based guidelines weren't being applied. So the sentinel effect in having evidence-based guidelines is absolutely critical as you start to review, even if you have the 95% approval rating.
Okay, Billy, it looks like, and Dr. LeFebvre, it looks like our second question is, with the greater focus on social determinants of health and health equity for this complex population, what are some key steps to addressing social determinants of health and health equity overall?
Well, the first key is really stratifying your population, because you can't really do anything until you identify those members who are at risk for SDOH or health equity. There are a number of ways in which you can do that. Much of the research suggests that something as simple as a zip code will tell you who's residing in a food desert, for instance. So having a stratification model. And then a tracking system. You want to track to see if your interventions are really causing an improvement or not. Many folks are using clinical risk groups to do that. That'll show the progression of disease over time. And then developing your intervention strategies and how you can tie the resources available in the community to the person who may need them. The challenge in Medicaid is that many times it's something like housing that could be the intervention that's needed to address the SDOH, but Medicaid can't pay for housing. So really your ties to the community are becoming increasingly important, so that you can access and use those resources that are available in the community, even knowing the eligibility worker where you can refer them so that the family can get food stamps, for instance. So I would say it's identification, connecting with resources, and then tracking improvement or change over time.
Those sound like great suggestions. Our third question here from a panelist is, our participant is, can you provide some examples of concrete programs that drive down cost and increase quality?
Sure. Let me link that also to alternative payment models, because alternative payment models are kind of intended to do that, link payment to quality and improved outcomes. I think that if you look at some of the offerings that eviCore has, not to be an advertisement, but some of these models that accept risk in exchange for the prioritization of certain services, for instance, MRI or CT, those are good examples of models that represent an alternative payment model that can actually reduce your costs, reduce your spend, and increase quality, because you're applying evidence-based guidelines to inform the approval process. So you're not engaging in this game of denial. You're trying to get the right person, the right service at the right time. And that's what those alternative payment models are really all about, is how do we get healthcare off of a volume-based model into a value-based model that is driven by quality and outcomes versus just submitting a claim. That's spilling over into total cost of care models, where plans are contracting with providers for total cost of care, and providers are being more sensitive to what are they authorizing and why, because they're trying to work within that total cost of care model. So looking at what is used internally to support your operation will contribute to your ability to both improve your cost performance, as well as your quality performance.
Thank you. It has always been discussed that Medicaid is disproportionately children. This question is that changing? Are the demographics aging or getting older?
Well, depending on about 40% of the children in the United States are covered by Medicaid, 50% of the births. The majority of children, of people in the program now, are children, but the majority of costs in the Medicaid program are really around disabled adults. I don't think you're going to see an absolute shift in the Medicaid population. I think where you're going to see the change is the proportion of disabled adults moving into the program and the proportion of the dollars spent. So in terms of absolute lives, yes, the majority of the program is going to be children, but in terms of absolute cost, it's going to shift more and more and more towards disabled adults.
Lastly, I think we have one last question. This is participant looking for recommendation. I recently had a representative over the Medicaid department in one particular state tell me that anything we do to reduce their costs could have a negative impact on their federal funding or already allocated budget. Is there a strategy that could protect their federal funding and reallocate savings to other Medicaid initiatives within the state? Or are there federal restrictions that won't allow a state to reallocate?
Boy, I'd really like to talk to that person because I've never really run across that. It's kind of interesting on the federal side, there's almost unlimited funding because Medicaid is an entitlement program. The federal government is required to fund a program at whatever level utilization and caseload require. So there's not a cap on funding at the federal level. And even at the state level, when a state runs over its budget, they have to supplement that with additional funds because, again, it's an entitlement program. When you actually save money in a Medicaid program, those monies within the program can be reallocated to the Medicaid program to pay for more services, to maybe expand the number of people in a waiver. They may be talking about is an incentive for the managed care plan to save money because they're concerned the state is going to pull that back. And I think a conversation with the state Medicaid director would find that they could create an incentive model to plow those dollars back into the premium in a way that would reward the managed care plan. So there's a lot of opportunity there, but there's not a situation where saving funds is a downside for either the federal government or the state government, or really necessarily the managed care plan.
Thank you. It seems that we've covered all the questions from our participants. Again, thank you, Billy and Dr. LeFebvre. I think this is extremely informative and, look forward to the opportunity to converse in the future about this.
Yeah, thank you for your time.
Thank you.